Consistent with Australian custom, I'd like to start by acknowledging the traditional custodians of the land that we are meeting on here today. That's the land of the people of the Haudenosaunee Confederacy, specifically the Seneca Nation. And we pay our respects to their elders and to their rich culture, tradition, and stewardship of the land for many centuries. Bronwen, when she speaks, will also acknowledge the important role of lived experience in suicide prevention. So I'm really happy to be welcoming Bronwen Edwards here today, who's a passionate advocate and an innovator in suicide prevention. I personally have been on my own journey of understanding, including learning from lived experience of suicide, really sort of starting in around 2016 or 17, and Bronnie's work in Australia has been really inspirational for me in that. So I'm really thankful that you're here with us today. As the founder of this and the CEO of Roses in the Ocean, Bronwen has pioneered the meaningful inclusion of lived experience in suicide in Australia. After losing her own brother to suicide in 2008, Bronwen channeled her grief into an organization that has become Australia's leading lived experience of suicide organization. And under her visionary leadership, Roses in the Ocean works to build a more compassionate and effective approach to suicide prevention by amplifying voices of people who have firsthand experience. Bronnie, as you'll hear, brings both heart and also strategic expertise to her work. They've partnered with governments, with health services, and communities to develop programs with impact. And her, again, as you'll see, warm and authentic approach has been really sought after in really internationally in this area. And when Bronnie's not leading transformational change all over the world, you'll find her at the Queenslands, this is the state that she lives in, beautiful beaches, and spending time with her family. So would you please welcome Bronwen Edwards from Roses in the Ocean, Australia. Thank you.
Thank you, Tony, for those beautiful words. Very kind. I'm always nervous when someone's going to introduce you and how much they'll embarrass you. But thank you very much. So look, I too would just like to acknowledge the traditional owners on these lands that I'm here today, and also from the lands on which I've come from. I come from a city in Australia called Brisbane, which is known as Meanjin to our First Nations people, that is on Turrbal and Yagara country. So I pay my respects to their elders, past and present and emerging also. And to also recognise everyone with a lived experience of suicide. There will be those of you here in this room today. I see you and I recognise you for being able to bring that particular lens and insight to the work that you do here, which is really important, but also to remember all of those people in your country, in mine and around the world who are bringing their lived experience to enrich the work that we do in suicide prevention, and to also just take that moment to remember all those precious lives that we've lost to suicide. So yeah, it's a real privilege to be here. Thank you so much. It's really wonderful to be able to see Tony here. We see Tony in Australia quite often, which is, we're incredibly fortunate for that. So I feel very privileged and special to be able to come here and visit you all as well. So let me just start by talking you through how we define a lived experience of suicide. And there's a story and a history to this as well, which I'll share as well, because I think it's important in understanding how we've landed on this definition. So we define a lived experience of suicide as someone who's experienced suicidal thoughts, someone who's survived a suicide attempt, the people who support their loved ones through crisis, and those who've been bereaved by suicide. Back in 2012, the first lived experience advisory group was pulled together in Australia. There were 6 of us. I was very lucky to be part of that first group. And it was pulled together by our peak organisation called Suicide Prevention Australia. And that's where we started to think, well, what is this thing even called? Like, what is this thing called lived experience? When my brother Mark took his life in 2008, and the preceding years that led to that, the word suicide was barely mentioned. Help was very difficult, if at all possible, to find. And if you found anything, it really wasn't particularly helpful. The term lived experience meant nothing to me. When I founded Roses in the Ocean, all I knew was, for whatever reason, no one who actually walked the shoes of suicide seemed to be having any input into the help that was available, or the help that was available for those of us that were left behind. And so when this first group of 6 came together, we started to really explore, well, what does this mean and how do we define this? And what is it that we really need to have coming from people who've walked in these shoes? And so initially the definition included, it actually talked about caring for someone through suicidal crisis, and you'll see that those words have changed slightly. And it also had a component at the end that said, and anyone else who's been impacted by suicide. And we sat on that for a little while, but then we actually collectively came to the decision that actually that wasn't okay, that wasn't defined enough. Because what we needed was, we needed the people who knew what it was like to get to a point where the only choice they felt they had, the only option, was to actually end their life. We needed those people to be able to tell us what they needed at that time and what was bringing them to that place. We needed the people who knew what it was like to check on their kids' bedrooms multiple times during the night and get there in the morning and just hope that they're alive. We needed the people who know what it's like not to have that person at their dinner table every night. And whilst we absolutely recognise that clinicians are incredibly impacted when they lose a patient to suicide, or our first responders are impacted enormously when they are constantly going to help people in crisis or are finding people who've taken their lives, they have a lived experience in those experiences. But that wasn't the experience that we felt was so important that was going to inform and transform what suicide prevention looked like. So the definition was reduced to this very specific, where it's if you think it's in your heart and your gut, that's where you feel this when you've got that lived experience. That's how tight we wanted this definition. And over the years, because of the power that we know that language has, there's a big shift in Australia now where people don't want to be known as carers. Not caring for your partner or caring for your child. You're not a carer. It's like you're a wife or a mum or a husband or a brother or a best friend, and you're actually supporting a loved one. So that's hence the shift in the language from caring to supporting here as well. So with that in mind, set about establishing an organisation that only employs, engages people with a lived experience of suicide. So that is one of the very unique aspects around Roses in the Ocean, that everyone within our organisation, that's now grown to 42 staff, we've got about 20 contractors, and by the end of this financial year we'll have close to 180 volunteers with us. Every single person has a lived experience according to that definition. So our vision, as you can see there, is that every person has access to effective suicide prevention supports that are informed or led by people with lived experience. So it's a pretty lofty goal, and you'll see in a moment when I sort of take you a bit through the types of things that our organisation does, how that plays out. And our purpose right from day one, when the organisation was founded in 2011, has always been to save lives and reduce that emotional distress and pain. So they're our North Stars, I guess, in everything that we do. So just to give you a brief sort of overview, where it's really, it's interesting when people come and join our team, I will say to them when I first meet any new staff in the first week, okay, be kind to yourself, because this is going to take you a good couple of years to really get your head around the depth and breadth of the work that we do. And I don't think anyone actually believes me at the time, but I have staff come back to me 2-3 years later going, I finally feel like I'm across what we do and I feel confident in really going forth in this work. I think what we've always tried to do is keep our feet really firmly planted in the dirt. So walking alongside people with lived experience just like ourselves, being in community, supporting people, but also at the same time I knew that if we were going to actually change the system, so really have that systemic change that we needed, we had to be working very strategically. We had to be rubbing shoulders with the decision makers, because 13 years ago, people lived experience had no power in our country at all. So we had to play the game, and we had to be able to come to the table and operate from grassroots to strategic level. And so our activities reflect that. And it's why we've always resisted the call for us to become a national peak body, because in our country, essentially peak bodies are representative of members and they don't actually do stuff. And for us, everyone who comes to work at Rose and the Ocean is so passionate about, yes, changing the system, but also changing the experiences and improving experiences on the ground. So we do a combination of both. So a large part of what we do has always been building the capacity of people with lived experience of suicide, helping them find a way to bring their voice to whatever part of suicide prevention they want to be involved in. How do they couple the skills that they have from other walks of life, careers and what have you with their lived experience? So we have a whole suite of that sort of work. We do a lot of work in helping to develop and support an emerging suicide prevention peer workforce in the country. We run non-clinical peer-led services, a national warm line, which is a callback service where we peer match people. So someone who's made an attempt can ring and we can connect them with someone else who's made an attempt so that they can get that mutual shared experience of conversation. We have peers in community supporting people face-to-face, and we have our safe spaces, which I'm going to talk to you about in much more detail. We do work in communities, helping communities to really recognise and respond to people in distress, so really empowering communities to be part of this broader suicide prevention system that we're trying to develop. And everything that we do, and for us, but also for lots of other organisations and service providers, we've really tried over the years to develop very specific ways of going about community consultation and co-design when you're needing to bring in those most valuable voices of the people who need those services, who are using those services, the people with lived experience, in situations where there's often significant power imbalances and different paradigms in which people are coming to the table with. So we do a lot of co-design and consultation work as well. And then we do a lot of work. I have a whole team. When I say a whole team, we're a small team. We have a team of 3 who actually work with researchers like yourselves, service providers, government, in connecting the right voices for the right projects and wrapping that holistic support around people to make informed decisions about what the project is, about their readiness to be involved, bringing the right voices depending on what sort of research is being done or what service is being designed or what have you. And then we use all of that work to inform our policy and advocacy work, our consulting and advisory role to government. So it's fairly big remit, but it all makes sense to us. And I think after all these years, our board have finally realised why actually everything in our strategic plan is really interrelated and we can't not do something. You know, boards love to say, what else could you say no to? And it's hard to say no to. It's really hard for a group of people with lived experience to say no to anything that's going to help someone else, but it does still have to make sense. But it all does support each other, which is nice. Okay, so the main point today is to share with you about our community-led safe spaces. It's very new for us. We're still learning a lot, but it's incredibly exciting work. And in fact, I was just sitting in Professor Pisani's office just before, and I got an email through to hear that one of the safe spaces is just opening now while I'm away, which is amazing. So to give you just a little bit of a timeline that's up there, it was back in sort of 2017-18 when the then Health Minister asked us for our opinion on what we really needed to do to change what was happening with our suicide rates in Australia. And we presented a paper around a whole raft of non-clinical peer-led services, alternatives to the norm, offering people some other choice and option to the very traditional biomedical approach to suicide prevention. not to replace it, but as an and a very important and how do they integrate. We built off what had already been trialled in Brisbane by a mental health organisation with a Tier 3 model, where Tier 1 was very much community-based, just empowering community members to be able to recognise if someone walked into a pharmacy and was just a bit distressed and look, have a glass of water and you're fine to be here for a bit. Tier 2s being more of those community hubs. I'm not sure what the equivalent is here in the States, but where people might come, for example, to get some food if they're struggling to put food on the table, or just come for some general social connection. Tier 3 was mental health services. So we wanted to build on that, and Tier 4 was to be these non-clinical safe spaces built on the safe spaces that were in London. There were at the time about half a dozen of them, where people could come if they were in distress, and it was just a safe place to be instead of going to an emergency department within a hospital environment. And then a Tier 5 was the dream of following the model that's been operational for about 25 years now in London called Maytree, which is a residential safe house for people in crisis, once again as an alternative to going to hospital. So that's what we had proposed. So we were really fortunate in around 2019 that one of the governments in Australia decided they'd actually put some money behind this, and they wanted to look at what an alternative to emergency departments would look like. And we were engaged to co-design that process for 20 of them in New South Wales. So we did that, and we designed what that had to look like. We had to really, as I said before, really had to work out how do we bring these very different groups of people together, which is another whole sort of conversation, I think. But what it did was it gave this opportunity for Australia to dip their toe in and try it. What came out of all those co-designs is essentially what we're now trialling in what we call community-led safe spaces. It wasn't what actually got implemented in New South Wales at the time, because we're talking 5 years ago. The risk appetite was different then than it is now. And the funding was actually funneled down to our local health districts or local hospital districts, basically. And you had clinical directors and what have you there, and boards that were very, very nervous about the idea of having what community were actually asking. So what has happened in New South Wales is they have 20 what we call safe havens, and they're a blended workforce model of both clinicians and suicide prevention peer workers. And look, we are incredibly supportive of multiple models, because I think human beings are as varied and unique and complex as any system, more so, and different people will want different things. But that was the birth of the community-led safe spaces, because we really wanted to honour the co-design outputs of what community had told us. And so we then decided to pilot that. We piloted 4 of them ourselves, and then through some national suicide prevention funding, we were able to get some project funding to expand that trial, and we're in the final of the 3-year project of that now. So what it looks like, there on the left is just an overview of those tiers that I just spoke about. On the right there, though, those key components of a safe space are what people had actually asked for, and that's the basis for our community-led safe spaces model. So a trauma-informed no wrong door approach. So literally no wrong door, no exclusion criteria, nothing to meet. If you're in distress or you just need connection, or if you're in crisis, you can walk in the door and you'll be welcomed. Non-clinical support, so no clinicians on site. The safe spaces, what they need to do is build very strong relationships with all sorts of supports, including clinical support, but also including supports that are related to a whole range of social determinants, recognising the more contemporary understanding of suicide in terms of situational distress. So building really strong networks where you can make really warm connections. Compassionate and capable peer-led workforce. So it did mean that we are still in the process in Australia. We're right at the beginning of developing that very sort of specialised suicide prevention peer workforce. We have a mental health peer workforce, The vast majority of the people in the mental health peer workforce will have been people who do have a mental illness and have been what they call, and thankfully the language is shifting in Australia as well, but the consumers of mental health services. Many of them, though, will have also an experience of suicide, but what we're trying to build out in Australia is that suicide prevention peer workforce where you've got a mixture of peers who have that underlying contributing factor that may be a mental illness, but you also have peers whose underlying contributing factors may be relationship breakdown, transition distress, financial concerns, whatever other things may have led people to distress. Needed to be a really safe and accessible location. People were very, very clear about it not being on hospital grounds, preferably in a lovely house that literally just had been repurposed as a safe space. They're hard to find and they're expensive, but that was what the aim was for. People didn't want it to feel like you're walking into a reception area. So there's no sort of benches or desks where you've got to write your name down and be triaged. None of that happens, okay? So it's really like, and people are known as guests, not clients, not patients. You're welcoming a guest into your home. Warm connections to supports I've already talked about, and that people with lived experience and people in community were actually part of the governance and management of these safe spaces. So to give you an idea of how we are going about, what we've decided is that thankfully I've got a board who've grown with me and whose risk appetite has just grown exponentially as well, which is incredibly fortunate when you're trying to break new ground. So what we are now as an organisation, we auspice these community-led safe spaces, but the community own them, run them, establishment, everything. But what it means is in the first 3 years, we are able to say to them, right, we've got all the insurance covered, your volunteers are covered, we provide all the training, and in that period of 3 years, you will, and with us walking alongside you, develop your fundraising skills, develop your relationships in community, such that you can stand on your own 2 feet. So we go through, this is our second tranche. So we had our pilot of 4, a first tranche of 6 or 7 or so, and then a second tranche. And each time we've learned and we've improved the processes along the way. And when we do the next lot, it'll be improved again. What we learnt was we needed to have communities come to us when they'd actually done a bit of the groundwork. So we hadn't required that in the beginning, and it was much harder to get them off the ground. But the second tranche, for example, has been a lot easier because communities knew that we needed them to have a small group of people with lived experience of suicide who really wanted this in community. They needed to have had conversations in community to know, yep, this is something we want, and have had a bit of an idea of where they might be able to locate, be provided like free of charge access. So some people are operating in cafes that close at 5 in the afternoon and then they open up as a safe space in the evening. Some are lucky enough to have been able to gain some additional support from their local council, what have you, and are renting little houses. So it really depends on the community and what's there. So we go through a whole process of really bringing these working groups together. We provide training for them to like, okay, you're 6, 7, 10 individuals. We need to help you work together. How do we help you understand the different roles that you can take in your working group? Who's going to be chair? Who's going to be treasurer? Who's going to do some admin? Who's great at IT? Who's a people person and can go and get support? So we just help those working groups form. We start mentoring them straight away, so they get fortnightly mentoring for the whole time that they're with us. We help them with all the marketing and collateral. They choose their own logos. We provide all of that sort of support. We provide them with $20,000 a year, that's Australian dollars, $20,000 a year as just operating funds. But because vast majority of them are not paying rent and it's a volunteer model, some of them are struggling to actually spend that money. We then provide really robust training for their volunteers. They go through a process, a combination of self-paced online learning and then facilitated learning to put all of that into practice, role plays, intervention skills, cultural awareness training, LGBTIQA+ training. So we provide all of that, and volunteers can go through that at their own pace, but ideally within sort of 3 months. And then we have communities of practice, ongoing learning development, digital portals for them to access resources and all the templates they need, and any additional training that we put out. And we help them with their recruitment of volunteers. Look, some of our safe spaces have, 40+ volunteers available to be on different shifts of evenings. Others in more remote areas have maybe only 10 people. So that's one of the restrictions to the amount of times that they're open. But they tend to look within their own community and go, okay, one source is looking at EDs and when are the most ED emergency department presentations happening. Okay, these are the nights that we open. Or there'll be other factors, but we actually run a full day local adaptation of the model as well, so community can come, hear about the model, give their ideas, share what they think they need and what would work, and then the working group determine which nights that they will be open. We also provide them, policies and all of those sorts of things that they can then be starting to customise as they sort of move towards their own independence. And we do a lot of the targeted marketing through social media and what have you to help them with all of the different events and recruiting that they need to do. So this is just a map of where they are at the moment. And in addition to these, we have one that we're trialling as an online space. So we have a national men's lived experience network, and they found that every second Sunday there was a group of people that were just wanting to come together who were just struggling a bit more than others. And so we're trialling what an online safe space looks like as well. As you can see, they all can have their own identity as well. It's not about roses in the ocean. We prefer to be that organisation in the background, uplifting community to have and be what they need for each other. So most of them end up with their own logos as well. These are just a few photos of various openings and places in which they're being set up. We get extremely excited when another one opens and what have you. And just briefly before I hand over to Tony, just in terms of next steps for us, we're always trying to think, the biggest thing I think around these spaces is sustainability. And it's really difficult if your working group starts shrinking in size and there's only a handful of people who are really holding this space. So a lot of our work is going into constantly around supporting those working groups. But we're also looking at, well, what happens once they move out from underneath our auspicing arrangements? We still want to be able to provide some arm's length support. So we've just developed a national community-led safe spaces agreement such that they can sort of stay in the fold and we're there to assist. And we're hoping to be able to bring them together at least annually, preferably twice a year, so that representatives from each safe space could come together, learn from each other, share ideas, share challenges, brainstorm and what have you, and we can provide some additional ongoing training and professional development and what have you. Evaluation for us is really, really tricky. So we do have a national evaluation of this project underway by the Australian National University, but it's really hard collecting information from people who are at that time in distress. And so it's not just our service, there's others that are having the same challenge, of course. And so, one of our big focuses is to be trying to work out, get really creative on how we can actually evaluate these services, because obviously funders and governments want to know that they're working. We want to know that they're working. How do we collect that incredible, powerful qualitative data in a way that's also appropriate and safe? So, that's an ongoing challenge for us. And we're launching our new strategy in July of next year, and we have set ourselves the goal of opening Australia's first residential non-clinical peer-led service by 2030 as well. But we want a good 3 years or more to really co-design that well and get planned for it. So anyway, I'll hand over to you, Tony, and then I'll be really happy to answer questions at the end.
Zoom room's open for questions, and this will be in a moment as well. The reason why I wanted Bronwen to speak to our department is that I think there's kind of two ways that we can take this information and consider what to do with it. One is, how can we learn from what these community-led safe spaces are doing for making our existing traditional services more open, inviting, friendly, more voluntary, respecting of people's dignity. We've made great strides in that direction, and I think that's the heart that everybody here has in our services. But there are ways that we're set up that are quite different. And so one way I'd like us to consider is, well, what of these things could we take and learn from for the services? But I'm also curious about, as leaders in our community, and really nationally, are there some, what about these models could we also promote in the community that are outside of a traditional healthcare setting? So, and depending upon where you sit and what your role here is, you may be wanting to think more about, gosh, I wonder if we could, what could we change about our service to make it closer to these kinds of models? Or some people might be thinking, I wonder how we could promote in a community a true community-led kind of service. So those are the kind of things that I have in mind. And my journey with this started in one of those tier 3 safe spaces. This is in Wollongong, Australia, where I was welcomed by these kind people in. And one of the first things that I noticed was that there was a crack in the wall. And you wouldn't find that in our hospital, right? And it turned out that this safe space, the people in the community had helped to paint it and revitalize this older home. And when they came across the crack, the question was, what do we do with it? And rather than fix it, they decided to put a quote on it from Leonard Cohen, which is, "There's a crack in everything. That's how the light gets in." And for me, this was really instructive and began me thinking about, what would a place look like that doesn't feel like you're coming into foreign territory, but maybe something that feels more like me for people who are experiencing distress. I got so curious, I was starting to think about it, knowing that we have excellent emergency care here, but it's a busy clinical environment, and that's not always ideally suited for emotional crises. I think we all probably agree on that it's that the coming into a hospital when your primary concern is emotional is not always the ideal setting. For some people, it may be what they want and choose, but for other people aren't, and a lot of people aren't coming. We know that most people who die by suicide do not seek out health services, and so I wonder what that's about. Part of it may be, and I'll share what we learned about this, that there is a risk of this involuntary process occurring, all the way up to hospitalization, and some people don't want that. But healthcare settings have, we have that as part of what we do, and in some cases there's obligations to do that, and so people may be avoiding it. I also, from my work I'll share about our partnership with the UR Recovery Center of Excellence. We've been really thinking a lot about rural areas and what they need. Some of our school-based projects that Peter Wyman has led were in rural areas, and I got to spend time in those areas and realizing, boy, it's a long way to the nearest service. Even if we had more friendly and services, they're a long way if you're going to put them in a metropolitan area. And then we got 988, and more people are calling in crisis. But I sat on the training and standards committee for 988, and the conversation was constantly, well, we don't know where to tell people to go in their communities. So I started thinking about this, and thanks to the innovative mindset and interest in rural health care and people with substance use conditions in rural areas, approached the UR Medicine Recovery Center of Excellence with funding from HRSA to put together this project and together with Safe Side Prevention, which has a lot of capacities around being able to convene people and the media and technology around that. So we did this project called Community-Led Safe Spaces in U.S. Rural Communities, ? And I'll share for about 5 minutes about that, and then I'll give you a link to the report that came out of that if you want to learn more about it. There were a number of collaborators that were involved in this. Bronwen and Roses in the Ocean helped to inform this project. United Suicide Survivors, a wonderful organization called the Wildflower Alliance, which has been around for like 20 or 30 years in Massachusetts, that has these kind of alternative approaches that are peer-led to helping people in distress. Colleagues at the University of Alabama, and then one of the lead, I want to acknowledge Heather Zell, who is an attorney at the Institute for Law, Psychiatry, and Public Policy at the University of Virginia. And the reason why we involved her as one of the directors in this project is that every time I came back to the US and said, you know, they're in Australia, I'm seeing these things, and people just come, they don't even have to give their names, and you know, they tell you and they're not gonna send you to the hospital, and people are like, yeah, well, wait till the first person dies, they're gonna be sued, right? Our minds immediately go to those medical legal concerns. It's just part of how we are, you know, and for good reason, but that's where our minds go. And so we thought, okay, well, if we're going to explore this, we need to have some attorneys involved too, and think about what would the legal and policy contexts need to be if we were to pursue something like this in the US. What would have to be different? What kinds of structures would take place? And so, with that, we went about a very preliminary work on determining, you know, is there interest, viability, what might be the needs, really just kind of steps that could be preparatory to future steps, either in research or others, to learn about it. So we gathered surveys from people with lived experience, held listening sessions, drawing, the team at SafeSide was able to draw from mostly rural communities for these listening sessions, held interviews with people who were working in mental health policy and other things. And I'll show you a little bit about what we heard. Interestingly, a lot of the things we heard were the things that Bronwen had been hearing in her sort of co-design sessions. But I wanted to highlight this one, which I thought was pretty interesting. On the surface, it seems kind of obvious. I'd imagine it'd be important to make sure that when people come to these spaces, they're not told there's something wrong with them, so they feel welcome. And we would all say, like, yeah, of course, like, who wants to be, but that's what a diagnosis is, and that's what we do. We diagnose and say, in fact, we can't even be paid unless we get one of those. And so you start to realize that a lot of the paradigms, now it doesn't mean that you know very well by knowing me, I'm not talking about throwing away diagnosis or any of those things, but I think it is really interesting that some people don't really want one. Maybe, you know, aren't coming in looking for what's wrong with them. And we heard a lot of different things. So when these were all directly from these listening sessions that we held, what's missing in the current services? And we had more than half of the people who had said, I have had suicide concerns, but I've never accessed traditional crisis services. So, which is a really hard population to get. Most of the time when we talk with people, they already are in the door. And you can see some of these things. I'll share a few here, and along with a story. One man who participated in one of these said, he said, well, I'd like some place where I don't have to talk. It's like, what? You wanted someplace that was nice. Well, when I'm in distress, I really don't want to talk. And when I go to any of the services in my area, that's the first thing they want to do. They want to hear about what's going on. And very well-meaning people who are trying to listen, but from his perspective, I don't even want to talk. And if I don't talk, then they think I'm being uncooperative, and I'm not trying to be. So he'd sort of be, he felt like he'd be sort of labeled as uncooperative if he didn't talk, but he doesn't really want to talk. And so it's a man who, well, what is there? What do we have for somebody who is looking for support in crisis, but doesn't want to talk? Because that's what we do. I mean, it was a surprise for me, because I'm like, I like to process stuff. I like to talk about, when I'm having trouble, talk through my emotions and everything. So, for me, it sort of seemed foreign. But he was really teaching us a lot there. Homey, not feel medical. Having peer there is no law enforcement. Having somebody, a peer who's a companion for you. So we didn't describe safe spaces to them at first. We just asked them about their current experiences and what they were hoping. Then we sort of described, well, here's one model that we're become familiar with. What do you think about it? And here were the questions that people asked. And their reactions. Are there guidelines about what can happen? So people were also wondering about that too. It's not just us as clinicians who wonder, like, are there any rules around this? Because it doesn't maybe totally sound safe if anything could happen there. So it's not that people are just asking for a total free-for-all. What happens to people? Or just, I like it. I would recommend this. How can we train the peers? How is this funded? Is this across the board resource for addiction and other people too? And this was a person who had addictions and wondered, do I have to have a suicide concern to come, or could I just come? I'll, in the interest of time, just move to some of the things that we learned from the legal and policy experts. If we were to try to pursue something like this in a community, one was that it may be best not to pursue a direction like licensure, because actually that might create more problems. But there was a lot of discussion among the experts about whether could a healthcare institution help lead a community-led, non-licensed entity. What role could a healthcare entity play? If there was more regulation, there's more liability. And that people may be overestimating, though, the duty to act on imminent threats. It's actually narrower than usually assumed, which I thought that was a helpful reminder that, that the objection that, well, if somebody is telling us that they have, suicidal thoughts or plans, we have to take action. That actually, that their autonomy may be more able to be honored than we might think. And then there were some other ones about funding and being clear about what they do and don't do. And there would obviously need to be a lot of consultation around insurance and liability. So those kinds of things came out from that. If you'd like to see the report, you can download it with that link. And with that, Bronwen, if you would come up, we would love to hear thoughts, comments, points of intersection that you might have, or questions. And I'll look at the ones for people who are online. They gave me the iPad with your questions. So if you want to ask them, I'll make sure to try to track those as well. So thank you. Yes. Oh, actually, Sean, I'm so sorry. I was supposed to tell you to go to a microphone or the Zoom people won't hear you. The Zoom people.
Hello.
Hello.
Thank you very much for this fantastic presentation. One of the things I was thinking through, I was thinking about our community, or some of the, the diversity of culture and languages that we use in our community, and how walking into a safe space will only feel safe if I'm a Spanish-speaking person, I need to make sure, of course, that if I do want to talk, I can talk to somebody who speaks Spanish, et cetera. So I don't know if I don't know, and I still don't know what that looks like in all the various areas around Australia. So I don't know if you could maybe speak to how you would consider navigating those experiences, or and maybe how that was contemplated to the point of where we've gotten to so far in this study.
Yeah,
Thank you.
Thank you. Such a great question. I was sitting there thinking, oh, there's so many more things I could have and should have spoken to you about. So what we've found in Australia so far, so of the 14 that we have now open, we have one Spanish-speaking safe space down in South Australia. And when we were in the process of helping that community, we used interpreters and what have you, because we don't have Spanish-speaking facilitators. So we lent into community to be led by them in terms of what does that space need to look like for them. And it is literally a safe space for a Chilean community that speaks Spanish. We have an Aboriginal Torres Strait Islander youth community-led safe space up in Darwin, once again completely designed by them. We've just given them some additional funds so that they can go and design their own training, because they've got some people who'd be amazing volunteers, but they don't have the literacy levels to go through our type of training, so they're going to develop their own. And we've recently had a Tamil safe space open also. That took a good 12 months of our facilitators just working, being led by their community leaders, their faith leaders, to understand, firstly, how can we even talk about suicide in this culture? We've been fortunate, we've been doing work with the Tamil in South Sudanese for many years, so we had some background in that. But it's because it's completely community-led. But what we are finding is that there are communities who are wanting their own safe spaces, but then we're also trying to provide all volunteers with at least that base cultural awareness, cultural safety, such that no matter where anyone walks in the door, at least there are people who understand they need to be very cognizant of different cultures and needs and be asking the right, yeah.
Thank you. Others?
Thank you so much for your presentation. I have so many questions, I'm gonna just limit them. So sometimes creating these initiatives create a new market, and one of the purposes I heard is to decrease ED visits, and I'm wondering if actually that was accomplished, or ED visits stayed the same and you created a wonderful, valuable program, but did not really meet that expectation.
Could be different. It could be different people, right? The people
Exactly.
who aren't coming now. Yeah.
Exactly.
I know we don't have the data.
We don't have the data yet. We don't have the quantitative data yet. Definitely anecdotally, we know that we're attracting people who will not go to an emergency department. So that's a plus. We know that we've got people coming who would normally go to an emergency department, but they will. There are people in rural Victoria who are driving an hour and a half just to be able to come and sit and be, because they feel safe and they know that for the time that they're there, they're not going to make an attempt on their life. So yeah, I don't know that we'll ever call it.
And very quickly, I just want to say, I would love to learn more about this. On top of my head, I know several community organizations that would be willing to work with us, for example, on something like this. So this is great. Can I have one more question also?
You're the community.
What kind of promotion? What kind of promotion for the community? What kind of education? I mean, when you put this out there, did you have television ads? Did you have? I mean, how did the community know of this?
Yeah, I wish we had the budget for TV ads, but we don't. So a lot of social media, a lot of just activating community in their own community to be going and talking to people, running community training sessions just to raise suicide literacy in community, and then the consultation day where you invite people, but putting flyers up everywhere, like very grassroots, to try and reach community.
Yes.
Hi, I am a peer and family advocate on CPEP, which is our emergency psychiatry unit. And one of the things that I'm really hopeful about the peer positions at the hospital, and I've just really loved working here. A shout out to Dr. Siri and the residents in particular who ask for my support, which is great. But we have a couple of positions open and we're having difficulty filling them. There's this fine line between, being well enough and certified enough to work on the unit. And if you have any ideas about how to recruit people, I'd love to see those other positions filled.
Yeah, thank you so much, and thank you for the work you're doing as well. Yeah, it's a great question, and I think we get a little bit of criticism sometimes that we need to sort of keep the narrative up around workforce, because our non-clinical peer-led services are predominantly volunteer-based. We are fully supportive of a paid peer workforce. What we find, though, particularly in around suicide prevention peer workers, so many people want to do something. They want to give a few hours. A lot of people don't necessarily want to embark in it as a full-time career. So for us, we're trialling this balance of a volunteer versus a paid peer workforce as well. And I think also just the more that we can break down the barriers and increase the lived experience informed understanding around suicide within our clinical environments, it will also make those environments, I guess, feel more welcoming and safer for peers to come. Most of the time that when we're providing support to our peer workers who are professional peer workers working in other services, a lot of the time the struggles they're having have got nothing to do about their lived experience or providing support to people in distress. It's working within a system that's not quite ready for them. So building up that foundational readiness in where they're going to work as well may help it to attract people.
Yeah. Just to add to that, I'll tell you what I wonder about it. In many ways, we're inviting peers to come into kind of like an existing structure that many didn't really have much say in creating. How it would flow, what kind of rooms there would be, where it would be. And so one of the things I wonder is, if we engaged and took really seriously a co-design process, even of our own services, whether that might open the door. If people are feeling like, wow, a lot of people, I participated in doing this and I want to work here, or people I know did and I want to work here. I wonder if that might create a different dynamic, because it is quite a bridge to walk over.
Hello, my name is Ellen G. Denton, and I want to thank you for being so inclusive of people that would otherwise have no place else to go. I think it was brilliant, your presentation. And so I have two questions. And the first is, do you have any examples of how these safe spaces would have managed patients individuals who destabilized or were in a crisis, came to the safe space and maybe did need more support? That's the first question. And the second one is a little bit more broad. What you imply through this presentation is a lot of destigmatization around the discussion of suicidal risk. And I know Australia was a British colony, and I know that at one time it was criminalized in Australia to attempt suicide. So I want to know if you can just speak culturally about the journey or how it got there and how destigmatized this discussion is in these safe spaces and how you got there as a culture. Thank you.
It ought to be easy.
Two big questions. So first question, in terms of how are people being supported to manage their distress, and that's right. So the safe spaces it's very much around how they're designed, soft furnishings, opportunities for people to use sensory items, either sit and talk with people or be on their own. Often there'll be outdoor areas. So this is the ideal where people can go. There was talk through co-design of having even a punching bag, like a boxing bag outside, if anyone needed to do that sort of thing, being able to listen to music. So really trying to think of all the different ways that different people might need and asking them what they need and then being able to accommodate that. There will be, from time to time, situations where someone who is in distress or in crisis may need some additional support and they may want to go to hospital. We've recently, end of last year and into this year, we spent 8 months within our own organisation and bringing in our lived experience advisory group and what have you to co-design what our position on 000, which here is 911. And we had to find that place that everyone was comfortable with, that we could honour everybody's risk appetites, I guess. Where that landed was that whilst anyone is within a community-led safe space, no emergency services will be called unless a person specifically wants them to be, and in which case a peer would actually accompany them to the emergency department and stay with them. Or if someone disengages from our service and they have said that they are absolutely going to take their life now and they have the means, that's the only time that we call, because we had to create this space where 99% of people feel safe coming to us. There'll still be some people who won't feel comfortable knowing that if they leave with intent, that we would still call for support.
Although Bronwen and I need to leave in about 20 minutes, but we will stay up here and let's talk about the other question here, and then if that can get extended. So we'll stay up here for additional questions, including yours, LNG. But for now, thank you so much, Bronwen. I appreciate you being here, and thank you all for coming.